My name is Fred Trotter. I've been working on health IT software for about 10 years, longer now. Most of it open source. I've gained quite a reputation for doing that. And then obviously a pretty substantial portion of that time I've been working with David, and we've worked on a lot of projects together, and including this book, which is the Meaningful Use book with O'Reilly. That's how we kind of how we're on the call together. And I think what we're interested in doing on the call is just talking a little bit about and connecting with the people who might be our readers and people who are interested in meaningful use and health IT generally about what's going to happen next. You know, what are our predictions? What are our what's our resolutions? Is I think the rubric, and so that's kind of why we're here. David, would you introduce yourself?
Sure. My name is David Uhlman. I'm the CEO of Clear Health, which is a company that about 10 years ago created the Clear Health and Health Cloud EMR systems, which are probably the most widely used open source, or at least GPL licensed open source EMR, EHR, practice management type systems out there. We also do a lot of facilities and practice and operations management in the healthcare sphere across fairly large institutions in several states, and serving about 14 million patients in our systems these days. And Fred and I connected on the Meaningful Use book. Both of us have a strong background in open source and open source software, and have been involved in healthcare probably as open source people about as long as anyone out there has. And this book is an opportunity to put some attention on ideas in healthcare that hopefully lower the barrier towards getting other smart, intelligent, inquisitive people who have some familiarity with open source and just kind of the concepts that represents into healthcare as an industry at whatever level, be that in the IT side, in just general business, in the medical side, in the clinical side, and so on and so forth. Today we have our kind of cheat sheet, 6 New Year's resolutions for IT that set a tone a little bit based on our experience, what we'd like to see and do and make sure we remember to talk about throughout 2012. And hopefully there's some really exciting things that will prove right, will be proven right on this year.
One thing, this is Fred talking again. One thing that I always like to do at the beginning of talks is kind of get to know the audience. And we can see kind of your names and the attendees and everything else, but that's not the same thing as knowing what you care about. So, you know, please use the group chat to throw out things that you think are important and you think are relevant. I can assure you that whoever is not talking between David and I will be watching the group chat, and we'll be trying to make sure that we cover topics that are interesting and relevant to our audience here. With that, can we start? Let me push the slide out to my first resolution. So one of the things that I think is going to happen, and I've talked about a lot, is what I call the health internet. And the reason I call it that is that what healthcare IT has lacked in the last, what healthcare IT has lacked is any kind of consistent platform on which to build interesting stuff. And the internet has been the platform that has been the thing to build interesting stuff on top of for years now. So much so that people take it for granted. People don't really connect how things like the Apple App Store or Amazon's Kindle or these kinds of things that are kind of really interesting technology things are really only late technologies that leverage the internet. And the internet, TCP/IP is just this kind of fundamental layer upon which everything else is built, and even the higher layers. I mean, one of the things is that SMTP and HTTP are these protocols that have allowed these really interesting things to be built. So my first resolution is to push the Direct project, because the Direct project, I think, more than anything else that I have seen is an opportunity to create that substrate that interesting things can be built on top of. Now, the basic, what Direct is just a particular configuration of secure mail. Now, one of the things that I think David might be able to comment on it as he kind of responds to mine is that I think the alternative Direct is just non-standard secure email transactions, which is to say people encrypting zip files or something like this and putting medical files and encrypted and using standard email to move files around. That counts as health information exchange under meaningful use as long as you do it with the right constraints. And so all directed is a kind of formalization of exactly how everybody's going to do that. So once you have a standard mechanism for moving healthcare data around of any type, and I think that's key. That direct is designed to work with some of the kind of fancy healthcare XML protocols like CCR and CCD, but it also works with random stuff that you might want to put in an email. It's just an email system, so you can attach anything you want. You can attach a PDF, you can attach XML. If you've got data that you've been tracking for your own heart rate, for instance, and it's in a comma delimited file, you can give that to your doctor securely in a HIPAA-compliant way over direct. Obviously, Microsoft, in probably what I think is the most ironic statement I'll say on this whole call, Microsoft has been tremendously supportive of this open source protocol. That's not something you hear every day, but that's been absolutely true. The Microsoft Health team is behind Direct. I think it's really going to go places. I'm planning on promoting it, but I just found out yesterday that Houston has health information exchange that has been using Direct. They're in their pilot process. I'm in Houston. I don't have anything to do with the Houston HI anymore, and I was thrilled to hear that. Because, I think that's an indication that this is really kind of a prediction, a resolution. I'm going to be continuing to work on Direct, but I think a lot of people are going to be taking it up too. And I think there's actually going to be a lot of kind of direct-ish stuff too, where people are using secure email to move files in kind of a predictable way that's also going to be valuable. But more importantly, I'm interested in seeing what other people build on top of that infrastructure. So that's my first resolution. David, I guess you can respond to my resolution and then go on to yours?
Sure. This is David. I think I really agree with what Fred said in the most part, but I do take a little bit of a different tact on it simply because of the time I spend in sort of on the ground in clinical settings and in operating some of the facilities that we're contracted to manage. And I definitely like Direct. I think that one unresolved issue is that in meaningful use being the federally sponsored reward dollars for particular behaviors in the use of electronic systems in healthcare. They didn't really take a stand on the specifics of how information is exchanged, only that information be exchanged securely. And they gave people some tools in meaningful use certified systems to do that, a tool for encrypting data with AES 256 and some tools for tracking the data that's exported from a system in a particular format, be that a CCD, continuity of care document, or CCR, continuity of, Fred, what's CCR stand for?
Continuity of care record. It's record versus document.
Record. So fairly similar, though slightly different formats, and those can be exchanged via email or anything else. The thing I like about Direct, or just in general, I think the thing we've learned in a long time in IT across any industry is that email wins. So when you give people email, they tend to use it, the tool, the paradigm, everything about email, we still use it today, even though many, many things have come along that threaten it a little bit or pretend to threaten it. Certainly Facebook and that is something on the horizon, but email is still the dominant app for everybody today. I think the larger question with something like Direct that still is very much unanswered is who's going to use it for what? And I guess I think that's also why Direct might be successful, and that doesn't make any assumptions about that. But when you talk to clinicians on the ground, there's a couple well-defined paradigms about sharing information between each other that relate mostly to what's done a lot of times by fax machine. And so you might be moving that into a more secure, more digital realm, but not by much. I think there's a much more fundamental question, which is outstanding, which is what benefit can physicians and providers of all types get from sharing information, and what motivations they can have to develop a new level of trust that they don't have today about respecting and trusting that information from other systems and other facilities and other providers so that they can use it without having to rerun your lab tests at every single facility you go to, without having to redo imaging studies that have been done a week or a month prior and so on and things like that. So I think that Direct potentially presents a solution to a problem that isn't fully defined yet, and that'll be the interesting part about what goes on in in 2012. I think 2012 will offer a lot of insight into that process as the potential penalties and so forth come along in the near future towards facilities that don't employ meaningful use systems. So I think Fred just moved the slide ahead for me. So I'm going to talk about probably my top resolution for 2012, which is the burgeoning and exciting things happening in what I would call mobile health. And that is maybe a very broad term, but mobile health to me means the use of all these new mobile devices and mobile paradigms on iPads and iPhones and Android systems and cell phones and personal quantification devices and things like the Fitbit and the Jawbone, similar Jawbone device and so on and so forth, and where those fit in what's a very stodgy, conservative kind of healthcare industry. To me, healthcare, we're in 2012. Healthcare is probably in 1982. So the idea of using computers for things in healthcare in a very broad way for the processes themselves is still an incredibly new idea. And so mobile health is this thing that's, sort of the future, quote unquote. But from a personal standpoint for individuals in American society today, mobile is the normal thing. You can't hardly find a person anywhere without a cell phone of some kind. And as the power of those devices continues to grow and grow, it presents really interesting opportunities for what you can do with healthcare and what you can do with devices and monitoring of real-time information and putting all those different pieces together. So the crucial underpinnings of this new thing of mobile health to me are a generational leap in certain types of devices. So a good example of that would be the artificial pancreas, which hopefully will come to fruition in 2012 for wide availability across a lot of patients. And that's nothing groundbreaking in terms of technology. What it is an insulin pump. So for those folks that are diabetic, either type 1 or type 2 diabetes, insulin is the medication they can use to regulate that disease. And as the blood sugar level changes, they need to be applying different levels of insulin. So there's a little electronic device that they can connect directly into their bloodstream that allows them to pump insulin at a very precise rate throughout the day and simulate in many ways the pancreas that most of us have. And up until very recently, that was a standalone device. You as a patient or you as a provider actually programmed the rate at which that operated and the types of tests you'd run on yourself, either a stick test or some other more advanced readings. You'd read that with one tool, and then you would plug that into the other tool, the insulin pump, and that would manage your diabetes for the day. Somebody finally figured out that, hey, wait a minute, you can take these two things and connect them together electronically, so I can have a real-time analysis of your glucose level, and I can connect that to the insulin pump, and it's a completely hands-free, automated thing that services the real needs of somebody with this disease in a very hands-free, very easy way. And then finally the next person came on and said, okay, wait a minute, we can shrink that down. We can actually just put it inside, and that's it. Then that is essentially all of the primary roles of a pancreas, and especially with relationship to diabetes. So nothing groundbreaking there, but the miniaturization of all those pieces, the thinking of putting all those things in a mobile system really just came together very recently. Tied to that on the other side, on an individual basis, you have this huge, exciting, burgeoning movement of people tracking themselves using a very unique set of different tools to learn about their activity levels throughout the day, their heart rate, their diet, their types of interests and movements, all the way down to blood oxygenation over time, managing mental health, managing all these things in a way that has never really been done before. People have certainly kept journals and all these types of things, but now you can have this real-time electronic database that on a second-by-second basis knows how you were active, knows what you ate, so on and so forth. And that has resulted in this explosion of data that we don't know the implications of it yet. It obviously has an enormous impact on disease and your own health, but we're just now scratching the surface of how to look at that data and decide what to do with it. So, okay, you certainly like French fries the first week of every third month of the year and things like that. What do we look at with those correlations, how we put those things together? We'll talk about that a little bit later, but that explosion of data is getting dropped on healthcare as a system, and nobody knows what to do with it yet. So that's going to be something that really has to get worked out in the very near future as the use of those devices just continues to skyrocket. That also creates a different interaction with your provider. It's no longer acceptable, and you have all that data sitting there to have a once-a-year sort of annual physical with a provider. It's just unrealistic to think that you're going to digest an entire year of data in that one type of interaction. So what is the new idea about how I work with my medical professionals, or there are new types of medical professionals that have to come into the picture to analyze that and help me understand the impact of that on disease I may have or treatment I may have, so on and so forth. And finally, I think the other big piece that relates to those things that we've seen across almost everything, but not quite in healthcare yet, is this idea of gamification and merit badges. So now on Facebook and all these other social networking sites, you can perform real-world activities of some sort that give you a merit badge, simply a status icon you can use to relate to your peer group to say, you know, I've achieved this in this game, or I've achieved this in my personal training, or I've achieved this in managing my blood sugar, all these things. And so the impact of that on an underlooked aspect of healthcare, which is your motivation, which is why do so many people have a hard time maintaining weight? Why do so many people have a hard time maintaining blood pressure and things like that can be treated for the most part without drugs and without traditional medical intervention, things like walking 30 minutes a day or being a little more careful in food selection, things like that healthcare has done an awful job at managing and interacting and succeeding on. Hopefully now, I think some things like gamification, merit badges tied in with this explosion of personal data has a potential to impact those things in a way we haven't seen before in a positive direction. So that's where I see mobile health coming, and maybe Fred has some comments too on his thoughts on mobile. Fred?
Yeah, sorry, David. I actually didn't mean to move your slide forward. Sorry about breaking your flow there. That was an accident. But I think, obviously, you know, I agree with David a lot. That's why I wrote a book with him. But I think he's absolutely right here. And there are two things that I wanted to highlight that he was talking about that I think are absolutely true. One is there's a whole group of health IT professionals and kind of, you know, people who are doing a wonderful job really pushing health IT into the 90s. And I think that's a perfect way to think about it. It's computers are really useful. There is the PC revolution has not happened in many deep ways in the doctor's office and in hospitals that just don't really leverage these tools that have already revolutionized everything else. And I think that traditional approach is both, kind of limited and not good enough, and also kind of needs to happen. I mean, we need to have the PC revolution in health IT. That needs to happen. We need to move forward. But then that creates the secondary movement that's kind of riding on top of this. It's moving much faster, going much farther, doing much more interesting and innovative things, which is all the stuff that Dave was talking about in health. I absolutely agree that we should be working on, as health IT professionals, working on technologies that make people healthy and keep people healthy, as opposed to helping them when they are sick. We obviously need to do the latter as well, but if we can keep people well rather than letting them get sick, that's the software that's going to really win out. Obviously, I'm huge into gamification and behavior change and all this kind of stuff. I've been running some really cool, interesting experiments. I actually have a new app out on Runkeeper for people who are Runkeeper users. But these kinds of things are going to take over. I think it's going to be the most important part of what Health IT is working on is leveraging these mobile tools, these personal devices, in order to change people's healthcare up front, because that's the only way we're going to really start addressing the cost. So I agree, and more so to what David said. Now that I understand exactly how to move the slides forward, my second resolution is to continue pushing technologies that are radically open to the patient. So, the two open source projects that I've been working on lately, David and I worked on electronic healthcare records, Clear Health, together years ago. David continues to push Clear Health with some amazing things with that. And in fact, if you're interested specifically in meaningful use, besides reading our book, which you should absolutely do, the source code to Clear Health is probably the best, and well, I think it's the most readable source code that is meaningful use compliant that you can find out there. So I think that's really important. But I have moved on to working on open source projects that do other things, and one of them is the Direct project, and the other one is essentially what you might call an audio personal health record, which is where you go to your doctor, and while you're in the doctor's office, you record the last part of what your doctor is telling you. You record the takeaway, and you have that as an audio file. And there's another that's sponsored by a nonprofit. There's actually a commercial competitor, so that idea is kind of coming forward. And then there's a third project, which I think I should highlight, which is the Open Notes project. It was sponsored by Robert Wood Johnson Foundation, which is really, really an amazing notion. The basic idea is that when you go home, through the PHR, you have access to your doctor's notes immediately. Now, the doctor's notes, you have always had access to them, right? Because you have the right to your entire health record under HIPAA. But HIPAA has these time dates, and it's like you put in a request, they have so many days to do it. I mean, if you want to have real-time decision-making based on what's going on with your physician is doing, HIPAA does not really help you that much. And Open Notes is radically real-time, radically open, and gives you access to the doctor's notes in the same way that these kind of audio PHRs and your doctor's advice and other projects like that give you access to the doctor's audio. And Direct gives you email access, which is something that's never really happened before. So when you see these things together, what you should see, and a common theme here, is that healthcare is becoming radically open towards the patient. The patient is not just going to have access to data. It's going to have radical, real-time, faster, richer, deeper, more meaningful access to what their physicians know and what their other healthcare providers know. And that's going to be happening. It's going to be happening much faster, and that's one of the reasons it's radical. But it's also going to be happening in a much more deep and real way. So, one of the things that let's say you're going in and you're a woman who's been losing weight, and things have been kind of going badly for you, and you're asking your doctor, well, why am I losing weight? I'm losing weight. I'm not trying to lose weight. What's going on? Or something like this. Now, maybe your doctor in the notes is writing anorexic ? Well, that's not really a reasonable diagnosis under those circumstances, but it's in the notes nonetheless. It has all of these insurance implications. And in the past, those kinds of like hidden kind of notes to self have gone into the patient notes, and maybe patients find out about them years later when they transfer to another doctor or something else like this. But now the doctor's notes could become something you're accessing in real time. And obviously what that forces the doctor to do is, instead of making a note to themselves they don't tell you about are you anorexic, but it brings that conversation to the room. So the doctor knows he wants to put that in the note, so he or she has to say now, look, are you having trouble with this issue, or is this kind of thing going on? So, I mean, this radical openness, I think people don't really understand how this kind of openness really, really, really does fundamentally change how healthcare works and forces conversations that you wouldn't otherwise have. With the audio PHR, it's the same kind of idea. The idea is that you're not recording what your doctor says. You're recording what your summary is of what you think the doctor's telling you at the end of the visit. So as you're talking to your own cell phone and saying things like, hey, yeah, I mean, I'm supposed to ice my knee for 3 weeks, and I'm supposed to take this medication this many times a day. As you're mirroring that stuff back, which mirroring is a classic communication technique, as you're mirroring that stuff back to your physician might say, no, that's not what I said. What I said is this. You misunderstood. So what that does is it creates this kind of formalized mechanism for forcing good communication practices, which means that the actual meeting has more value, but then you have access to the corrected version of what the meeting result was 6 months from now, and you can't remember how exactly the doctor told you to take your pills. Well, that's radical openness. And I think the Direct project, which is to say that you have a way to directly email your physician, is similarly open. And I'm not sure exactly what these things mean, but I think pushing this as far as we can go is a good idea because I think there's going to be really positive changes that are not immediately obvious with the way you start to open up. So, David, what do you think?
This is David. I can offer just a couple small adjuncts to I think what Fred said, which is true. And I think there's maybe two specific examples in patient-provider interaction that a more open approach offers some real benefit. And one of those is that in healthcare, inevitably, there's some fairly complex topics about risk management and some really difficult decision-making that often you as a patient are being asked to make, or your sort of representatives are being asked to make it at a really critical, sort of intense time in the process. You might be sick, you might be even potentially fatally ill, and now you've got to look at all this information in an objective way and make clear, concise decisions. And I think that healthcare has historically done an awful, awful job at properly educating patients about the decisions that they need to make and about the implications of those decisions everywhere from the exam room to the emergency room. So they hand you this form, which most people don't even read. It's a consent to treat. You sign it, and then they do what they want to do. And I think that with a more, it really is a culture change, but with a culture change brought about by having much more openness in the record process and the record generation process. I think that's a positive impact on making sure that physicians go out of their way to spend the time and energy and use proper communication to educate a patient about the decision that's going to be made so that they understand all of the implications of that and maybe can make a better informed decision about whether that's the right decision for them. I mean, I think unfortunately we've seen healthcare a lot, sort of the old cliche that to a man with a hammer, every problem is a nail. And so when you go to a hand surgeon, it's nine times out of 10 you're going to end up with a recommendation for hand surgery. It's just the way that healthcare has been trained to operate. And I think as all these data sources come together, as patients hopefully can take a little bit more responsibility for the information that they're giving to the provider, the information they're getting from the provider, that'll improve the situation there. I think Fred touched on an example. Maybe I can present a better one, which is that there's some awkward conversations that often have to happen between a provider and a patient. One of those that's become incredibly prevalent is in prescription drug abuse. And so there's a whole lot of people out there that end up getting improper treatment on one way or the other. So I might have a ongoing chronic pain, and eventually I run into a physician who's become very skeptical that I'm having pain, and maybe I'm having the pain, but the physician thinks that I'm not, and really just trying to get some more prescription pain meds or whatever it is. And I think an open records approach really changes that type of interaction so that there is an honest or a more honest level of communication between a provider and a patient that can hopefully better resolve some of those difficult conversations that do have really long-term implications, not just on insurance, but on patient care. If you're in chronic pain, one of the absolutely frustrating things that you run into in today's system is it's very difficult to get treatment for that, because unless they can find a problem on an imaging system or find something they can see or touch, physicians are very reluctant to provide any kind of relief to those situations. And so an open records approach, I think, is a new tool in the toolbox to try and resolve those things. And I think with that, that's probably the best comment I can make on the open patient ideas, except for some other things I'm going to touch on later on my resolution number 3. But I'm going to dive into my resolution number 2, which is big data. And I really view this as sort of giving the Hubble Space Telescope to ancient people in the ancient world. We have this enormous quantity of new information coming in every day from all these individual gathering systems, from new medical technologies, from imaging technologies. Now we're looking at real-time monitoring of illness using essentially tiny little robots that you ingest in a pill form. Whole new concepts, new frontiers, 3D printing of new organs using your own cells, all these sorts of things that all depend on enormous quantities of gathered information. That information might be, say, your real-time, heartbeats across a year, or these large spans of time. So an amount of data that really has never been thought about or conceived of in healthcare before. And it builds on maybe the past 10 years in technology as a whole, which is you have companies like Google and Facebook and all these things that came to an important realization, which is that if you have a large enough quantity of data, correlation is enough. And what I mean by that is that you can make really quality decisions based on correlation alone. And that's really a new and problematic concept for healthcare. Healthcare, medicine as a whole, as a science, is always looking for causation. And so they're looking for what the underlying cause is of something. What we're going to see now is that over the course of a year, we're going to find trends in data, in this big data, that relate and correlate very strongly with certain types of illness. And we're just at the tip of the iceberg now. And the question becomes, how do we use that information? And medicine right now doesn't use it. It does not use correlation as a pathway to treatment or to prevention. And we need, obviously, now to come to a point where we can use correlation, even if we don't fully understand the causation, to drive some of these pathways. And that is going to be a very uncomfortable change for healthcare, but to me it seems fairly inevitable. And I think 2012 is not certainly the year it's going to happen, but it's the year where really as an industry-wide type of system, the amount of data to make these general correlations is an important thing. And some of those are date and time. Obviously, hospitals know that there's certain busier or slower times of the year, and there's certain, sort of full moon syndrome and some other things. We're going to see that, but even in much more interesting ways. This goes back to sort of the Walmart diapers and beer kind of correlation. They can't always explain why that is exactly. They can speculate on it, but what they found is when they, at the front of the store, they can put in, they have a lot of people that come in last minute to purchase alcohol, purchase beer. But if they put some diaper displays next to that, they also sell a whole lot of those. So the person coming in for beer is also buying a lot of diapers. It's not a real answer as to why they're doing that or who those people are or anything more than that, but from the data they were able to see that and they were able to maximize on that. In healthcare, you're going to see a lot of things like that too. Maybe coming into Thanksgiving or coming into Christmas, you're going to be able to see in a real-time way the stress of the in-laws coming in on the respiration and heartbeat data or blood pressure data or so on and so forth, or maybe the inverse, long-standing assumptions that we've had about patient behavior we now may be able to see aren't quite as simple or much more complex than we understood them to be before. So that's going to be a whole sea change in almost every level of healthcare. On top of that, you now have meaningful use, which Fred and I wrote this introduction book about, but meaningful use is a new concept in healthcare. Federal government realized that the clock was ticking on healthcare, the system. Within 10 years, we were essentially bankrupt on healthcare. We haven't done a whole lot as of today to resolve that, but meaningful use is an attempt that's out there, was the attempt that's out there. We'll see how that pays off. But meaningful use is the idea that it was very difficult to get physicians to use electronic systems, so we're going to basically bribe them. We're going to outright pay them to use electronic systems in the way that we want them to use them. To me, meaningful use was a fairly subversive attempt, actually, so that on the surface it appears that the government's really just paying for these answers to these questions. But to me, the underlying reason for meaningful use, based on the history and a lot of conversation I had with people that sort of invented it, was that it was teach a man to fish, is that they wanted to do this experiment where we're going to pay you for this information, not so much because they only wanted that information. That information is very valuable. Meaningful use provides a new insight across a huge number of patients on chronic diseases like diabetes and hypertension and all those things. But it hopefully will be an avenue by which to teach providers, medical practices, large medical facilities, hospitals, to use data and use data reporting in a way to look at themselves and introspect on their own patient care and come out of that with a new understanding about how to do that in an ongoing way to solve all kinds of new problems. So I think that's the long tail of meaningful use that we won't see for some years to come, but will hopefully provide an ongoing benefit even once the dollars have been used up in motivating people to move to electronic systems. Finally, we have one big problem in this whole new concept, which is that you have all these people with these silos of information about patients. And HIPAA, as the law passed in the 1990s, provided fairly strong privacy protections to all of the patients involved. And that's a very good thing. But you now have some trade-offs that have to be managed very carefully, which is that if we were to take some of these silos of data and put them together and correlate them, we might develop some radically new ideas about how to treat these very significant chronic illnesses. At the same time, how can we do that in a way that's compatible with patient privacy? That's a really big unanswered question, and it's a really big kind of seesaw about for myself. I think patient privacy is really significant. The healthcare system as a whole is not all that great about managing that, and a lot of times now most physicians you go to have a variety of waivers and things you sign that for the most part you're giving away a lot of your privacy rights under HIPAA. To balance that against, though, the potential improvements in care and outcomes for millions of people, if we can tip the balance a little bit more away from privacy towards sharing of this information to create these correlations, that's a really difficult set of questions to answer. And I don't know there is one answer, but we have to continue looking at ways to do that respect patient privacy and hopefully come up with some new and innovative ideas about how to do these things without these enormous data privacy spills that we've seen from some systems and retailers and healthcare itself. So all those things I think come together. Big data as a whole is an important topic this year because it's touching on all industries. Healthcare now in the very near term finally has the inputs of information to provide good, new, high-quality, objective data into these correlating systems. We'll have to see what comes out the other end, but it's bound to be whole new insights into this information and into patients and human behavior as a whole and how human behavior relates directly to medical events. I think for the most part, medicine for a very long time has been thinking about sort of disease and treatment in isolation. And so now this presents a new pathway towards looking at the system as a whole and understanding that your real-life events that may affect your mental health lead into a rise in blood pressure and a series of other events that lead into some physical issues that lead into suppressed immune system and then more illness because of a new job that you've just taken. So this whole string of things becomes visible in a way that hasn't been before or hasn't been practically possible for a provider to look at before. Now they can, but the tools to do that and the experience and the whole concept of doing that is very new, and it's going to take a long time to sort that out, but I think 2012 is the year that starts. And so, Fred, do you have any thoughts on correlation is enough?
Yeah, but actually I want to go back up and start with your last line on your slide here is it the cloud merging with HIPAA and all this kind of stuff. And one thing that people don't understand about HIPAA is that HIPAA was both providing some radical new levels of privacy, but also provided for kind of a generous way to share de-identified data. As long as it's de-identified, and obviously that's a pretty broad if, like, being de-identified is not trivial, but as long as it's de-identified, you can share data for research purposes for all you want. So this is one of those cases where the law and then the actual implications of how the law has been viewed are totally skewed. So the law says we should be able to create these huge cloud, massive data stores of de-identified patient data, which would benefit everybody tremendously, and that's okay. And all physicians can participate in that without fearing legal liability because they can de-identify patient data. But what HIPAA did is make everybody really, really paranoid about sharing data, period, whether it was de-identified or not. And so what has happened is that there is this kind of lag. HIPAA actually allows for and encourages these things to happen, but it has just not happened yet. So I think people need to actually understand more about what HIPAA allows and the implications about what HIPAA allows, and also studying the science of de-identification more carefully so that we can solve some of these problems and create this big data. And I think one of the things that I think, and now turning back to what David was specifically focused on, medicine is myopically focused on causation. And the irony is that I would say medicine is myopically focused on the pseudoscience of causation. And I think that's an important distinction, and I think that's the reason why this correlation point that David is making is so valid, is that one of the things that happens in healthcare is that people start forgetting that the human body is an evolved, complex system that talks to itself in a myriad of ways that no design system would ever do. And so we find a correlation like a basic correlation, like cholesterol. If you have high cholesterol levels with bad kinds of cholesterol, you have a much greater risk of heart disease, or blood pressure is correlated with heart disease. And so what physicians do is they say, well, make these dietary and exercise changes so you can lower your blood pressure and get your cholesterol under control, and so that your chances for getting heart disease work. And of course, there's all kinds of research that comes, that those interventions really work well, and those are good things. But then we start to do things like, okay, well, let's create a drug that will artificially lower your cholesterol or artificially lower your blood pressure or something like this. And something that happens a lot, and a lot of the reasons why these drugs never get out of the market is that what they'll find is that, great, this drug, when somebody takes it, their blood pressure is absolutely under control, but their whole cardiovascular system just goes haywire, and they have actually a dramatic increase in their incidence of heart disease. And the reason, of course, is that what people fail to keep in mind on a kind of constant basis is that we're using things like blood pressure and we're using things like cholesterol measures in these tests as indicators of how a system is functioning. But it's not the same thing as the system. Right? The system is really complicated, and we don't really actually know fully how it works, but we're watching these indicators, and we realize that if we control these indicators via diet and exercise in kind of macro, normally good ways, that, we get these results, that's great. But when we eat right and when we exercise these kind of things, those are kind of system-level things that are kind of known good things to do. And when we try to actually just change the indicator by itself using pharmacology or something else, we don't understand how things are impacting the system. So we fail to understand the causation, even the kind of simple basic indicators a lot of times, and we fail to understand that what we've always been working with always has been correlation, because we understand so little about causation, and it's just in a system that is as complicated as the human body. Causation is just causation is a 20-year information problem, but I think David is right. Correlation is a 2012 problem. This is something we can solve and get really interesting data that we're not really going to understand, but what we're going to get is system-level interventions that we don't understand the causation, the underlying causation, but we can actually use these to control in a way we can. And we're going to have the opposite problem, where now we've got system-level things that are actually making people healthier, and we don't know why that works. Well, that's much better than getting subsystem level interventions that we think we understand the causation, but we really don't, and they really don't work. So, I mean, I typically agree with what David says, but I think it's really important that I don't think we even have causation down right now. I think we're obsessed with causation, but I think it's a pseudoscience in many ways.
Well, I want to inject one more thing, Fred, just quickly. I want to leave you time for the ACO, but one of the other things that comes up in a lot of the research that's done today, and one of the interesting things challenging a lot of drug companies today that relates to big data, is what I would call sort of the dark matter problem in healthcare, which is this placebo effect. So right now it's been almost impossible in the past 5 to 10 years to get new antidepressant medications approved by the FDA, simply because the clinical trials for those drugs have shown a lot of efficacy in a lot of these new treatments. However, the effect of a placebo has increased dramatically. So the same types of trials you might have run 20 years ago versus today, that sugar pill is actually much more effective today than it has been in the past. And nobody has really any idea or any concise idea about why that's going on. And big data potentially offers some new tools to look at that type of information. So that would be something really interesting that could come out of all this collection of seemingly useless data. Maybe finally we get a little bit more of a grasp on that sugar pill effect and how that maybe has very broad implications for a lot of other treatments. So I just wanted to mention that, and I'll hand it back to Fred here for his third resolution.
Yeah, I think actually, David, I mean, as I'm kind of changing slides over, I'll just comment on that. I think understanding the placebo effect and understanding the deep implications and the crazy things that modern placebo effect research have had is probably the kind of underestimated thing that every health IT person should understand. I think it's actually kind of root knowledge, and in fact, we should remember to include it in a book next in the next go around, because it's really important. Okay, so I'm going to go a little quickly through this because I think this is really obvious. Once I make the point, I think everybody will see that it's obvious. I don't know if it's obvious without having made the point, but accountable care organizations are the real ceiling for what meaningful use is going to change. And the reason is that using computer systems and using the reporting that accountable care organizations are going to be having to submit and these kinds of things that really are better about actually reporting on the health care of the patients, which is the reason accountable care organizations might work in the way that managed care didn't work, because you're actually tracking how healthy the people are. If you're not actually tracking how healthy people are, then managed care just doesn't work. But the capitated care idea, which is where doctors are paid based on not how much treatment they gave, but how many of their patients are healthy, that means that for the first time, I think, ever, really, because managed care just didn't care about this. Managed care used statistics on the back end rather than measuring on the front end, which is why it was fairly flawed. The accountable care organizations do exactly the opposite. They measure on the front end. All of a sudden, this is the first time when clinicians, clinics, hospitals are going to realize that they have a competitive advantage with information systems. And ironically, this is just because of the way healthcare has been paid for in the past. This has not been true, but I think this is a big change. And if you can increase and lower the cost of managing a patient, if you can make a diabetic healthier, but also use less of the doctor's time by using a good communication system, a good PHR or whatever, I think you have a financial incentive finally to do innovative and kind of interesting and different things. There's a lot of companies that I see coming out of Health 2.0 and the kind of the cool kids of health IT. They're trying some really innovative and interesting things that, even 3 or 4 years ago, if they'd asked me, people always ask me, is this business a viable idea? And Health 2.0 people let me judge their contests a lot. And I would have said, that's a great idea. That's a wonderful idea, but it's not going to work because of how healthcare is paid for. And now I don't have to say that anymore. So I think that's huge. I think that's really, really important. And I think what meaningful use does is say you have to do X, Y, and Z. What the accountable care organization does is say you have to make people healthy and control your costs. And those are kind of fundamentally different things. One is prescriptive, and the other is opportunistic. Embrace whatever technologies you think gives you the opportunity to make money in this model. And I think that's going to be really important. So, David, I can hand it back to you.
Sure. I think we all know that healthcare is broken, and that at least in the current pace, it's going to bankrupt us. There's really not any debate about that. So the question is, what do we do to try and resolve that? ACOs are the new idea about how to do that. I think in a common sense way, they make a lot of sense in especially based on many previous attempts which did not make common sense and failed. So ACOs are, in essence, instead of measuring particular things, we're going to measure the patient's outcomes as a whole and remunerate you based on those outcomes as a whole. So healthier people, potentially you make more money. Less healthy people, you lose a little bit of the reimbursements you've ever got. It does offer some interesting challenges in changing the type of relationship we have with your provider, in that those awkward conversations we touched on a little bit earlier may become more prevalent, and that could be a good thing, could be a bad thing. It's a whole new set of concepts. I think, unfortunately, the pace to move to ACOs has slowed quite a bit, and so I'd love to see the federal government pick that back up and begin pushing really hard on, and that may happen based on the outcome of the pending election. So I think that would be the only other comment I'd add there, and I can kind of touch on, I think, my last resolution here, which hopefully encompasses a lot of the things both Fred and I have already touched on this call, and just our feelings in general, which is my new resolution for 2012, and it's a relatively new idea for me, is what I'm going to call Hack Your Health. And I've been in healthcare now for probably about 12 years. And when I first got into healthcare, I thought, okay, I was coming from a background in a lot of industrial process and manufacturing and these big ERP type systems. I thought, okay, we're going to be able to change this system from the top down. And I think after about 5 years, I realized that was just never going to happen, or I was certainly not the person who would be able to do this from the top down and solve systems that way. You might be able to do that for one system or two systems, but healthcare is really 250,000 small systems, and it just doesn't work in that model. So I think then middle of the last decade, I thought, okay, now we're going to change from the sort of provider level up. We're going to work with providers, and we're going to figure out how to improve their tools and improve the interactions they have, and that's going to solve the problem. And I think just now, in the beginning of 2012, I realized, that's not going to work either. That is just, or I'm not the person that can make that happen. So in 2012, I decided, all right, what I see and what in the past, when there's been this impossible to disrupt system that needs disruption, it's really us as individuals that are on the hook to make that change happen. And so that's what I'm asking people to do this year is hack their health, is as a patient, take a new level of responsibility for your interactions with your provider, take the same type of approach you would use in almost every other aspect of your life, but that people are still so reluctant to use in healthcare, and apply that to healthcare, apply that to your own health. Do your comparison shopping and talk to your friends about things in detail. Question, be skeptical, all of those things that you would do in every other industry. Now I want people to apply those to healthcare. I want them to use their new tools like Fitbit and everything else, Runkeeper, to monitor their own health in a way and become an expert on themselves and to find those correlations and to challenge physicians and their own providers about why they're feeling ill and why they think they're feeling ill, and to not take no as an answer. Because up until now, in so many settings, it's very unusual for patients to even ask basic questions about their care. And to some extent, providers have felt that it's almost an affront to their care to have that happen. I think the ACOs and all the other things change the model. They open this new level of communication, but patients have to take responsibility for that and achieve the improvements that they want to see by pushing forward themselves rather than expecting these other top-down or provider-driven initiatives to really affect that. And so my first point here is that healthcare has been, if anything, most successful at avoiding any sort of real change. And so that has to end. It's either going to end on the economic side, or it's going to end being driven by patients. So that's my strong belief for 2012. I think with this advent of electronic medical records, it behooves all of us to look at our own medical records. Most of us now check our credit report once a year for free. Medical record is so much more important than that, and most of us have no idea what's even in there. The number of errors that are made by providers, by what I call the healthcare system, is astronomical. It's shocking. Fortunately, most of those errors don't result in harm to you, but the errors happen nonetheless. I mean, if you think about your credit report and how many errors they make there, I sincerely doubt that healthcare even gets within howitzer distance of that level of accuracy. It's really bad, and so patients are the best place to begin to attack that problem and look at those errors, however small they might be, and get those cleaned up. I think that patients also tend to react badly and wait too long. They wait until things are sort of bleeding and hemorrhaging and run into the emergency room at the very last minute. So hacking your health involves looking at your own data and thinking about what's changed and thinking about what's wrong. I recently went to the ER for an infection that I had. I probably waited too long to do the same thing. But I think with the advent of these new real-time data systems, it gives you a set of tools to say, I was actually feeling pretty crappy the 2 weeks before that happened. And so maybe it's on me, the responsibility. I really should have gone to the doctor before then and said, hey, wait a minute, I have this data that's showing clearly something's wrong. Let's take a look and try and figure out what that is. So that's a new thing that ties all these tools together, but it's still the responsibilities on us as patients to initiate that change in process. So that's really where I'm coming out. And I think there's a lot of new technologies, too, that are just fun and interesting and allow people to interact with their health. For me, my own standpoint, I had a CAT scan, so I was able to take that CAT scan and put it into a 3D printer, one of these from MakerBot, and 3D print a version of my own skull from that information. So I had the CAT scan. At least I got some value out of that CAT scan. So now I have a little desktop paperwalk weight of my own skull printed in plastic. So neat things like that allow you to think about your health in a new way, interactive in a new way. So those are my big resolutions for 2012.
So I just posted to the group chat an article I wrote for Radar called E-Patients, kind of the healthcare hackers, hackers of the healthcare world, which I think backs up what David was saying. I think we've only got a few minutes left, so I wanted to talk to Catherine a little bit about some questions. I was going to go through and see if I had a favorite one, but I thought, Catherine, if you could just start us off, and we'll go from there.
Sure, I'd be happy to. So I'm going to jump back to the very beginning where Ashok, excuse me if I'm not pronouncing that correctly, asked if you have any thoughts on object-oriented storage for healthcare. And he said, I see a definite need and growth in this area, especially radiology, CT, and EMR.
Dave, I think you should answer this one because my answer is I don't care. And my answer is I don't care because I just concerned about different things, but I think David might care.
I think what you saw is that Meaningful Use really said, okay, we're going to use the CCD, which is a semantic XML to some extent about tagging healthcare information. I think that's what matters. So it allows big data to happen because so many different people are tagging similar things in a similar way. I don't think that there's much need beyond that. There's certainly, in general IT, there's all kinds of I guess that would maybe one point I'd make is that I think the question is a little bit backwards in that IT as a whole exists. IT affects healthcare just like it affects any other industry. There's a lot of tools out there for looking at object-oriented information. Healthcare data shouldn't be treated any different just because it's healthcare data.
Next.
Okay. Let me turn off my speaker. All right. So then there was a question, and I think this came up, Fred was talking. Do you consider eventually modern health, I think mHealth, I don't know what that means, going in the direction of using telehealth to manage patients remotely? I should reword that.
I think
yeah. Go ahead.
David, it's you.
I think that's one part of it, but again, I think that's kind of a myopic view. It's just like the explosion of Facebook and all these social networking things. It's unclear exactly what tools and avenues are going to create the interaction between providers and patients. Telemedicine does offer some cost control and a better interaction with your provider. And I think now that ACOs and things come along and change the payment equation for providers in a way that makes that possible and makes that economically feasible for providers, that we'll begin to see a lot more experimentation in that area.
I agree.
All right.
Next.
And then Paul was asking a question. Sites like mobilitywad.com, I'm not sure that's spelled correctly, are taking center stage lately. Do you think that's a trend or just a fad?
So I've never even heard of mobility WAD, so I don't know that it's not so much center stage that I haven't heard about it. Now, what it looks like this is, it just says on the front page of the site, I just went and looked at it, it says all human beings should be able to perform basic maintenance on themselves. And I think that's, I think this notion of the 4-hour body and these kind of really aggressive, here's some different approaches, different from what mainstream fitness and mainstream health professionals have been saying, but well tested and kind of backed by N=1 studies and these kind of things. These kind of things will become more and more and more important because I think what's happening is that essentially patients are getting to the point where they're so impatient with what's happening in healthcare that they're literally willing to do their own science. And I think that's a very radical thing. I haven't actually heard about that particular website, but I think that movement as a whole is extraordinarily important.
I'm always a skeptic, so that looks like a paid plug to me, so I'm going to pass on that topic.
Okay. All right. So Daniel asked something that sort of segues into what you were talking about. He said, are you talking about a kind of Facebook for medics with diabetes as a group, for example? What do you think? What are your comments on that?
I mean, I think David actually already said when someone asked about telehealth, well, what about Facebook? Imagine that kind of a paradigm shifting thing. I think the answer to the question is in our book we have this whole chapter on patient-facing software, and we refuse to lump that all together as PHRs. And the reason we did is there are sites like Patients Like Me is the one I always remember, that are really trying to have patient-to-patient interactions that are far more complex and essentially represent a kind of healthcare social media or patient social media. And I think even the differences between Patients Like Me, and I can't remember the names of their competitors off the top of my head, but even the differences between them are more significant than the differences between them and Facebook. So the answer is yes, but no. Yes, we're talking about something like Facebook where people can radically connect together and re-engineer something, but these ideas are so distinct that it's really hard to lump any kind of group in and say, except as to say that patients connecting to each other using electronic means is really going to change things. David?
When I see a question like Facebook for medics, I come back to that whole thing. Healthcare is not different than anything else. Why not just Facebook or Google Plus or whatever it is? I think that's the mistake that we make so often is that healthcare is different. We need a Facebook for medics. I don't think we do. I think we have Facebook. You have a whole generation of people under 20 right now where Facebook is the thing. And so I think for them, healthcare will evolve to a level where they're just as comfortable. I mean, they share everything on Facebook now anyway. The idea that I just got high blood pressure is going to be a normal thing to share on Facebook in 10 years. So I don't think that there's any real distinction that needs to be made for Facebook for medics. Those of us of a different generation, maybe that idea is very foreign and uncomfortable, but that's the reality of the demographic shift that's happening now.
Yeah, and people are doing it. I mean, one of the things we have in our little chapter and in the book is I kind of de-identify and republish a friend of mine who's using Facebook as their healthcare log. Now, is that the right idea? Is it safe? Is it wise? Is it prudent? I mean, there's a lot of reasons to be concerned about that. Sure, but it doesn't really matter because she's doing it. She's doing it there. Yeah. That's where she's doing it. She's not using HealthVault. She's not using Patients Like Me. She's using Facebook. So I agree with David. Don't try to resist the irresistible.
So you guys don't think there needs to be some kind of curatorship of the information or someone, a managing authority of this sort of information?
I think the Occupy movement, et cetera, there's an Occupy Healthcare, and Nate Osip is actually attending our talk here, which I think is really cool. But there is this notion that when you have radically open communication, leaders become substantially less valuable, and curation becomes substantially less valuable, and the right answer bubbles to the top. And so, yeah, I mean, I don't know. I certainly wouldn't want to be the guy coming in and saying we need to enforce some controls on Facebook and controls on Patients Like Me and all this kind of stuff so we make sure they work. I'd much rather sit back and wait for them to figure out exactly how the crowd can lead themselves without being in danger. I mean, I think there's a story of 2E patients, which I'll try to provide a link to once I stop talking, that everybody should understand and understand that you can go astray with these notions. But in general, I don't know. What do you think, David?
I think it's a double-edged sword. I mean, I don't want to leave, my chemotherapy dosing up to the hive mind, but at the same time, I think that there is a lot of value in these new forms of communication. I think the answer is we don't know yet, but I think having to put some sort of management or control is the first mistake. We've learned that with all new technologies, is that trying to lock that down, trying to put that on top as a step one typically means that no one uses it or it just doesn't get anywhere. So I think it's all up in the air. Hopefully people will use it in a way that's responsible enough so that they don't harm themselves or contribute to harm of other folks. And I think that's the best kind of baseline we can shoot for. But I think more openness, more communication at all is good, and the more data that ends up into this corpus that happens out there, the improvements that makes in correlation then become better and so on and so forth. So it's a sort of virtuous cycle. I think there are in healthcare some very long-standing opportunities for malintentioned people to really prey upon people who are sick and all that. So I think we do have to be cautious about those scenarios and things like the anti-vaccination movement and that, which present real present dangers to us as a society. But as a whole, I think that the outcomes have been positive. I think we're still, it's so early that we just have to wait and see and kind of ride out some of these crests and waves that happen.
Okay. What a fascinating topic. And, of course, it's something that everyone cares about. It's very close to all of us. But you guys have definitely presented a fascinating view on this today. So we have one more question. We're a little over time. I'm not sure I really understand what Esther was asking here, but it was about meaningful use. How would it apply for expensive small user-based medical devices like the microprocessor-controlled knees for above-the-knee prosthesis, that sort of thing. Do you want to take a quick stab at that?
Well, meaningful use really doesn't relate to anything like that. So meaningful use is simply about physicians using electronic systems to record their interactions with you. So it doesn't delve down into that base level of the specific clinical decisions they make or anything like that. It's just about moving them from a paper chart to an electronic chart and hopefully teaching them new ways to use a computer to record data and most importantly report on data about their patients and their patient base as a whole.
Okay, fair enough. All right, well, we're out of time, you guys. I want to thank you again for an excellent webcast and thank everyone who joined us today. What a great discussion we had. Great questions, good discussion. Overall, I think it was a very worthwhile hour, so thank you, everyone. And once again, to the people who joined us today, I just want to mention we will have a recording of this event, and we'll send the link out in the next 24 to 48 hours. I'm not exactly sure when. Feel free to share that with your friends, too. And I hope we'll see you all back here next time.